Welcome you to this morning's special presentation. I think you're going to be in for a treat. We have Dr. Timothy Gilligan from the Cleveland Clinic. By way of introduction, certainly it's a pleasure of mine to acknowledge somebody of his caliber, of his expertise. Besides being a medical oncologist who has a special interest in testicular cancer, he is well known for his communication, teaching skills when it comes to doctor-patient relationship. And that's something that all of us should strive to improve on a regular basis. Part of medicine is not just the fact that you provide sound medical care, it's how you communicate and how you empathize and also provide the compassionate care that you need to do. And that's the difference between an average physician to an extraordinary physician. And that is something that Tim has been quite well versed in that particular area. Tim is a faculty member of the American Academy on Communication in Healthcare and the co-director of the Cleveland Clinic's Center for Excellence in Healthcare Communication. Of course, his interests are in communication skills, facilitation, team building, feedback, and conflict resolution. Like I said, we are very we're in a treat this morning because you just don't get caliber of teachers like this to come to Windsor and to address this very important issue with all of us. I'd like to take this opportunity to thank the Windsor Patient Task Force for inviting Dr. Gilligan to be with us here today. Dr. Gilligan, please welcome.
So, I don't have a microphone. I hope everyone can hear me? It's there? All right, well, good. Well, thank you for having me. And I appreciate you getting up early and coming in. I have a 7-year-old son and a 12-year-old daughter and a working spouse at home. And getting to 7 o'clock meetings for us is a big challenge, because it's breakfast time is getting the kids to school, and she often has meetings, and so I appreciate your coming in. We miss too many of these meetings ourselves. I want to give a little bit of a just intro as to who I am and why I'm here, which really has to do with the work that we've done at Cleveland Clinic. Back in 2009, our hospital decided that physicians needed help communicating better, and partly they decided that because the government was starting to measure patient experience, and they thought if our doctors are going to be measured, then we ought to give them tools so that they can perform at a higher level, because otherwise they're just getting criticized but they're not getting any help. And so we built a program and have trained over 5,000 providers at this point in a one-day course about how to run an encounter with a patient or how to interact with patients in a way that you can build a more meaningful relationship with them so that it's more satisfying for the patient and also more meaningful for the clinician who's involved. And so we've had a lot of experience. 5,000 is a large number. And we spent a lot of time thinking about how adults learn, how do you change behavior, what's helpful to people. Because there is a pretty rich literature about what works in communication skills training and what doesn't. So that's kind of the background. But I wanted to talk, I think it'll be more interesting for you and more relevant, really about my journey through this process and what I've learned from it and what I think the take-home messages are. Because it's interesting, I was reading the publicity about me coming here, and I think it's always a danger to believe your own publicity. And so I come here in a sense as a purported expert in healthcare communication, and I do have some expertise, I guess, and I have a lot of experience teaching it, but in some ways, what really grounds this experience is going into the clinic and seeing patients and then seeing what happens there. And so I was in my clinic last week, and I had a woman come in who's in her mid-40s, and she's with her husband. And 3 days earlier, she'd been told that she has bladder cancer that has spread to her lungs. She has 2 teenage kids at home. So you sort of think about what is going on in this household. And what does this person need from the healthcare system? And I didn't really feel like that much of an expert in communication in that moment. What can you do? This tragedy is unfolding in this life, and yes, I know how to make empathic statements. I know how to be a kind person, but I don't know how to reverse what's happening there. And so I'm thinking, like, what are the tasks in front of me? I need to make a connection with this person. I need to give them information that's very upsetting. I need to find some way to preserve hope. I need to figure out how much information this person is ready to hear. It's our first visit. I don't need to tell them everything on the first day. But they're just staring at me with panic in their eyes. And there's a certain human reality in these encounters that I think we lose track of in medicine at some point. And I thought back on an encounter of a different patient I had seen years earlier. I'd had a young man who came in, and he had a cancer that I couldn't cure. It looked a little bit like testis cancer, so we hoped that it was, and we treated it as if it was, and it responded to treatment. And he got better, and then he got worse. And so I sent him to the leading expert in testis cancer in the world, who's Larry Einhorn at Indiana University, saying, I don't think there's anything more we can do, but I want you to take a look at it. And this patient's family was very religious. I think the father was a pastor, if I remember correctly. And they went and they came back. And I said, how did things go with Dr. Einhorn? They said, we had a wonderful visit. I asked, well, so what happened? He said, well, he agreed with you that doing more chemotherapy was not going to help at all. And there really wasn't anything more to be done to fight the cancer. And the mother said that what she remembers from the visit was, she said to him, you know, we're deeply religious people and we're trying to accept what's happening. And Dr. Einhorn said to them, it's unacceptable. And that's what she remembers from the visit, which I think was a way of him saying to her, I get what's happening, and this is, you know, more terrible than we can talk about. And that came back and that helped her, because she felt like she had been seen, that he couldn't cure her son, but at least he expressed to her that he could see what she was up against. And he wasn't telling her, it's going to be okay, or you'll get over it, or you'll move on eventually. He was finding some way to say, I can imagine what it looks like, and it's not acceptable to me, and there's no reason it should be acceptable to you. So when I reflect on these experiences, what it reminds me is that we're having really very difficult conversations in medicine, and that it's not a matter of us being bad communicators or unskilled. It's really a matter of us trying to go into situations that are very fraught, and they don't have to be these huge tragedies. They can be much more routine things. They're still complicated conversations. We often have to give patients technical information in terms that they can understand, and we trivialize the difficulty of doing that. I went to journalism school before I went to medical school. And in journalism school, they spend a lot of time teaching you how to do that, because they understand that regular people pick up the newspaper and they need to be able to understand it, or else they won't buy the next edition. So if you're going to write about the Middle East conflict between the Palestinians and the Israelis, you have to write about it in language that someone with a 5th or an 8th grade reading level, depending on which newspaper it is, can read it. So then they teach us, how do you write at that level? What words can you use and what words can't you use? How complicated can your sentences be? And in medical school, they didn't do any of that. I mean, I never had training on how do you explain to a cancer patient what a lymph node is, right? It's not that intuitive to a layperson what the lymph system does. I get asked all the time, well, if they remove 10 of my lymph nodes, am I going to be okay? To a doctor, it seems like a silly question. Of course you're okay. You have hundreds of them. You don't really need them. You know, unless you remove all of them in a certain area, you may get swelling, but it doesn't really. But to a patient, figuring that out, or if you just had a heart attack, how do you explain to someone what a heart attack is in terms that they can understand? So I think what's been striking to me in this work is that as human beings going through life, one of our biggest challenges is communicating with other people and forming relationships with them. And in medical training, we're not very well prepared to do that. The other thing that I want to talk about is the idea of whether or not we should want to get better at this. Because I think there's a lot of, certainly in the American medical world, there's a feeling of being criticized for not communicating well, or for patients being dissatisfied, or more hoops for us to jump through, more ways we're being measured, more ways we're being told we're not doing our jobs as well as we should. And what we've tried very hard at the clinic to do is to really reframe that and to think about what does it mean to be a medical professional. And if you look at other professions, Atul Gawande has written about this, about coaching that in a very powerful way in the New Yorker magazine. But if you look at other professions, they're always striving to improve, right? The Toronto Blue Jays, I was told, just secured their spot in the playoffs, right? So they're not saying, well, look, we got to the playoffs, that's pretty good, now we're going to go home and take a nap, have a beer, relax, right? We had a pretty good season. They're trying to get better. They want to get to the next level, they want to win the World Series, and if they win the World Series, they want to come back next year and they want to be better. So what do? They're practicing their skills all the time. Right? Before every baseball game, they're taking batting practice. How many times did these guys hit a ball? They still need to practice hitting it. But yet, do they want to get better? Serena Williams has a tennis coach because she wants to get better. There's a very impressive story about when she won her second round match in straight sets, she thought she wasn't playing well enough, so she changed her clothes into regular practice clothes, got her coach, and worked on her serve and her passing shots for an hour. Because it wasn't good enough. She'd just beaten another professional in straight sets, but it wasn't good enough. She wanted to get better. So can we think about communication skills in the same way? That fine, maybe I'm a good communicator, maybe I'm not. Maybe that's not an important question right now. Maybe the important question is, can I be a better communicator tomorrow than I am today? And is it part of my professional identity that I need to be able to communicate well, and I should always be striving to improve? Because if you're a classical pianist, you're always striving to improve. If you're a professional athlete or artist, you're always striving to improve. Shouldn't we in medicine do the same thing? And is communication an important enough part of our work that it should get some of our time? Every year I have to do 200 hours or 100 hours of continuing medical education. How many of those hours are around communication skills? Am I finding courses to help me communicate better, or are they all about understanding the pathophysiology of disease better? So those are sort of framing issues for me. So then the issue isn't whether or not we're good communicators, the issue is how do we get better? So I was thinking about my journey, so I wanted to talk a little bit about how I got here, because I think it illuminates some of what the work is that we have to do in this area. And for me, it starts back in medical school. When I was applying to medical school, I had a kind of complicated background because I was an English major. I'd gone to journalism school, and then I was saying I wanted to be a doctor. No one was sure that the medical schools would believe me, so I applied to everywhere I'd heard of. And at one of my first interviews, I was out on the West Coast, and I go to talk to this radiologist who's in the basement. I have trouble finding his office. I get there, it's kind of confusing. I knock on his door, no one answers. I wait, he finally opens it. He's angry I'm late, but I had been there, but he hadn't heard me anyway. It didn't get off to a good start. And he asked me, why do you want to be a doctor? And I said, because I think medicine's really fascinating, and I've been working in public health and politics, and I'm really engaged around public health, and I think medicine is just fascinating. And he said, those are really stupid reasons to go to medical school. He said, public health and medicine are diametrically opposed. He said, if you're a doctor, you want everyone immunized except your patient. If you're in public health, you want everyone immunized. I mean, it's a silly argument, but that's what he said. And then he said, medicine's not really all that interesting. Once you've been doing it for 10 years, it's the same thing over and over again. Your patient doesn't want to be an interesting case. Your patient wants to be someone you've seen 10,000 cases of that before, and you know exactly what to do. He said, there's only one reason to go into medicine. He said, if you're pathologically fascinated with humanity. And the irony to me is that this is a guy who's in nuclear medicine, so he's in the basement reading films all day. So I'm trying to think of, well, so why are you in radiology? But now, I'm going to turn 52 this year, I realized that he was right, that what's really interesting about medicine is all the people that you meet and all the people that you work with. And after a certain point, you are an expert in your disease, and it's not that challenging anymore. You can wake me up from a dead sleep, and I can tell you how to treat complicated testis cancer. I've just done it for so long. But going into that room to talk to that woman and her husband, that's still a challenge. And that's what makes it interesting, and that's what gives my days some sense of meaning when I do it well. And so, partly I think what I want to appeal to is improving our communication skills and our ability to connect to other people isn't just about patient satisfaction scores and making our bosses happier with us. It's fundamentally central to why we went to medicine and what makes it worthwhile being a physician. And I don't think any of us went to medical school hoping to annoy our patients or make them feel that we don't care about them. And so are we willing then to work on what does it take to convey our caring in a way that they can experience it more meaningfully? Another sort of story I wanted to tell that exemplifies some of our challenges in this department. We do leadership rounds in our hospital. I don't know if you have such a thing here, but we drop in on random floors and talk to everyone who works there or a representative sample and see how things are going. So I'm with the surgeon one day and we're going through the post-op area. And we see this patient who has a bandage around his head. And we go, usually we check in, we say, how are things going? Are they taking care of you? Are you getting what you need? Are the doctors telling you what's going on? And this guy kind of surprises us. He takes my colleague by the hand and he says, Doc, am I gonna be okay? We don't know who he is. We don't know why he's there. We don't know why he has a bandage around his head. And my colleague says, yes, yes you are. And the patient looks a little puzzled. He says, how do you know that? He says, I'm a doctor, I know. You have the best team taking care of you. Well, I'm an oncologist, so I'm not so optimistic. So I went and I grabbed the bedside nurse. I said, what's going on? She said, oh, he has pancreatic cancer. He has brain metastasis, so they just removed it. So this is not someone who's going to be okay, by most of our definition of okay. But it was interesting to me in that moment how strong that impulse was, that what we want to say as doctors, right? It feels really nice to say that. You're going to be okay. I'm a doctor. I know, right? But we don't know. And we make promises we can't keep. We're so eager to reassure patients because it's scarier to go into that vulnerable space of I don't know what's going to happen to you and I can't fix all your problems. And like I was with this woman in my clinic last week, I can't fix her problems, so I'm trying to figure out what I can do for her. And probably caring for her and helping her go through this journey is the most I'm going to be able to do, and I have to see the value in that and figure out what it means to do that skillfully. But I can't go to her and say, you're going to be fine. But that's what patients often hear, and because we don't feel like we have the skills to have the honest, fuller conversation. Another lesson I learned in this process, when I first went to the clinic, I got into big trouble. I had a patient who was a middle-aged African-American woman, and I had done a lot of research on healthcare disparities, and I felt very passionately about the gap in care between black patients and white patients, that skin color is such a predictor of the care that you get in our country is really deeply troubling. And she had come in with diffuse large B-cell lymphoma, which is a curable cancer, but is very deadly if you don't treat it. And she'd been so sick she went to the ICU. The previous team had started chemotherapy. She rapidly improved. I took over. We transferred her back to the floor, and she refused to have any more chemotherapy. So she was refusing treatment. She had a deadly disease. We could cure her. She wouldn't let us. So every day I went in and I told her about diffuse large B-cell lymphoma and the effectiveness of chemotherapy and what happens if we don't treat it. And I reminded her how sick she was when she went to the ICU and how we really needed to resume treatment. And eventually she called my boss and he fired me, and she complained that Dr. Gilligan was coming into her room every day and yelling at her. Fortunately, I had a fellow with me who testified that I didn't yell. I'm not really the kind of person who yells, but that's how she experienced it. And she transferred her care to a different hospital, and I don't know what happened to her. So my attempt to persuade her using my logical powers of reasoning to get the care she needed failed. And I took over the training program in hematology and oncology after that, and I decided I need to learn how to teach communication skills. And I had this wonderful mentor who's a psychiatrist, and he said, when people get seriously sick, their identity is taken away from them. And it's very important to take a careful social history to figure out who they were before they get sick, and to let them, before they got sick, and to let them reclaim that identity. So that you can see them as they were before they were sick, and so that they can see themselves as they were before they were sick. So they're not just this sick person in the hospital, because maybe they can't work, maybe they can't play with their kids, maybe they can't have sex, maybe they can't do their hobbies. Activities that are important to them have probably been taken away from them. So I got back to, it was ironic, the very first day after this course, I get back and I go on service, my fellow comes up to me and says, Dr. Gilligan, we're so glad you're here. We have this patient with metastatic testicular cancer and he won't let us start chemotherapy. I said, well, what do you know about him? And they say, well, he's 32 and he has seminoma of the left testicle and he has lung metastases and he won't let us start chemotherapy. I say, well, what else do you know about him? He says, well, he has seminoma and he won't let us start chemotherapy. So I say, well, why don't we go figure out who this guy is? So we go into the room and talk to him about his story. His dad has lung cancer. It had been treated and it recently relapsed, so he's now terminally ill, not close to death, but incurable. His mother, when she found out he was going to the hospital to have his cancerous testicle removed, called the hospital and canceled the surgery, saying Jesus was going to cure him. All right, so he's going to lose his dad, and his mom is interfering with his medical care. His girlfriend breaks up with him and tells him she's pregnant, and she's not sure if the baby is his or her new boyfriend's. He has a new girlfriend, and he's curious which, if either of them, is going to come and see him in the hospital. So this is what's on his radar screen, not whether or not he should have chemotherapy, and no one has talked to him about this. So I spent 20 minutes with him. We didn't talk about his cancer. I came back the next day. We talked a little bit about his cancer, and the day after that, he started chemotherapy. And I get emotional about this because I saw him in August, and he's 5 years out, and he's cured. So if I compare those two stories, in one case, I went in with my cognitive hat on, and I tried to argue the patient into treatment, and they never got the treatment they needed. And in the second case, I went in and I made a relationship with this person, and I got him to trust me, and to think, and to see that I wanted to see what his experience was, and we treated him and it worked. So again, these skills are practical, I think they're useful, but they're also about getting our work done. Communication skills are often talked about as some touchy-feely thing that we're supposed to hold our patients' hands, we're supposed to hug them, we're supposed to make them feel better, but it's actually fundamental to just taking care of people. So the last story along these lines I wanted to tell was I was rounding one day, and I go into the room. This is the inpatient oncology ward at Cleveland Clinic. People are very sick. People are dying, people are having abdominal pain and nausea and vomiting from bowel obstructions, they have infections, they have severe pain. And I go into this room and this patient is furious with us. You can just tell from her body language. And I'm trying to figure out what's going on, and I have 2 interns and a fellow with me, and she says to me, "My pancakes came today with corn syrup. You keep bringing me Gatorade to drink with high fructose corn syrup. Are you people trying to kill me?" And so I'm thinking, is this real? Like, am I dreaming this? I'm on the cancer ward, and I have a patient who's upset, the most upset patient because she got the wrong syrup with her pancakes. And you know what I want to say to her, which is like, grow up. Like, be grateful that you're not one of these other people. Or, look, I'm the doctor. I don't control what our food services purchase. Or I could talk about how maple syrup is really expensive and is not really a great use of healthcare resources to bring people pure organic maple syrup on their pancakes. But I couldn't say those things because I had 2 interns and a fellow with me, and if they saw me say those things, then I wouldn't be exemplifying Dr. Gilligan, the expert in communication. But I really didn't know what to say. And so I thought about, there's this slide in this course that we teach that said if you are working with someone who you don't like, try to find something about them that you like, or try to find something about them that you can authentically praise. It's not the patient's job to be likable, it's our job to find something to like about them. So I thought, what can I relate to with this patient? So I did not want to talk about maple syrup. So I said, it sounds like you really care about what you eat. She says, yes, I do. She actually immediately starts to seem to calm down. She says, I do. I cook organic vegetables and fruits for my family. We eat very little meat, very little sugar. I try to exercise, try to take care of myself, I try to take care of my family. It's very important to me. And actually, that's important to me too. And I said, that's great. I think food's hugely important to our health. And eating well is very important. I wish all of my patients cared so much about what they eat as you do. I said, we'll try to do a better job in the future. And after that, we were like best friends. But what really surprised me is that 2 weeks later, I got a letter from her. I took care of her for 3 days. I was not her oncologist. And she wrote me the sweetest letter I think I've ever gotten. Basically saying that, I'm so glad you went into medicine and you kept everything very positive in the hospital for me. What was striking to me that it had such an impact on her. And that conversation could have been negative, and we could have gone in a very, I could have very reasonably said, that's not my problem, I'm not going to deal with it, and we wouldn't have had a strong connection. And every time I went into her room, I would have dreaded going into her room and worried that we'd have another fight about it. And instead, by applying a technique I had learned in a course, we made a connection, we had a relationship. She was happy every time I walked into her room, and I got a very affirming letter that in some way I was on the right track in terms of how I was trying to take care of people. And so I had a much better day as a result of trying to make a relationship with the patient and trying to communicate more effectively. I don't know if she ever filled out a survey about her satisfaction with my care, but she let me know about it. And made me feel better about why I'm a doctor and what I'm trying to do. So what I'm hoping to show in these stories is that, from my perspective, communication is really about making a connection with another human being, which is often not on our radar screen as clinicians when we go in. In other words, when I go into a patient's room, is my agenda I need to make sure their blood pressure is under control. I need to make sure their diabetes is under control. I need to make sure they're eating a healthy diet, they're exercising. Whereas my agenda going into the room, there's another human being in there and I need to find a way to connect with them. And I need to think of relationship skills I can use that will make them feel welcome and safe with me and trusting of me. I need to earn their trust. Do we listen? I spend a lot of time shadowing doctors now. It's amazing how much we talk. And our training has reinforced that. We got through medical school and residency and got advanced by showing people how smart we are, by how much we know. We do it with patients too. Whereas in fact, listening to them talk is often, generally, much more therapeutic for them than having them listen to us talk. I think we give them way too much information that they don't understand and they can't hold on to, and we don't take the time to let them talk to us and give us the information that they have that we need to hear. So learning to listen well is a critical skill. And thinking about what we're hearing and making sure we're understanding it correctly. Right, so if I think of this woman with the maple syrup, what I heard when I went to the room is, I have this entitled, spoiled patient who wants pure maple syrup in the hospital, right? But that's not her story. Her story is, I have lymphoma and I'm desperately trying to get better and I'm trying to take care of myself and you people are sabotaging me, right? I eat healthy at home, I do everything I can, I come to the hospital and suddenly I'm eating the stuff that people tell me I shouldn't be eating. So she's just trying to get better, she's not trying to be demanding. But I have to listen to hear that and to understand that. Expressing empathy. It's one of the ironies. So if you look at studies of empathy, it's very clear that medical students lose empathy as they go through training. So the issue isn't, can we get people to have empathy they don't have? The question in some ways is, first of all, can we stop beating it out of people? And can we reawaken it? Because people are born with empathy. There's extensive research in primates and young children that people have empathic and mammals have empathic capacity. It's very sort of hardwired into us. And if you even think about it as in how we behave in our current lives, I think we can see it. So I'm home, and my neighbor, who's a doctor, let's say he slips on the ice, because we have lots of ice in Cleveland, and he hurts his leg, and I go running over to him, right? And what am I going to say? Oh, Richard, are you okay? That looks really painful. Can I help you? Do I need to, call an ambulance or something? And yet I see him. So we call an ambulance, he goes to the hospital, I put on my white coat and I go in, I ask him on a scale of 1 to 10, how much pain are you having? Are you able to put weight on it? Does it radiate anywhere? Were you drinking? Have you ever done this before? Right? But no statement of, gosh, I'm sorry you fell and hurt yourself. I wish this hadn't happened to you. That basic empathic statement, once we put our white coat on, we stop doing that stuff we know how to do. And I see that because often when I'm running role plays or having physicians practice these skills and they don't know what to say, I'll say, imagine it's your neighbor and you're sitting at your kitchen table and suddenly it gets easier for them. There's something about putting on that authority of being a doctor that seems to take away our permission to be human beings, and overcoming that is important. Giving the patient a little bit more control. One of the things I'm really excited about right now in medicine is there's a big push towards really partnering with patients, getting them to be actively involved in their own care. And I think how we communicate with them is very important around that. I think we do a lot to infantilize patients. When we go to medical school, they teach us that when people get sick, they regress. But what's striking to me is how much we encourage that regression in how we treat people in the hospital. We don't acknowledge their own autonomy. And so there's a really fascinating study showing the power of moving in this direction called Centering Pregnancy. It's actually a whole program, but they've done research around it. Centering Pregnancy is group prenatal visits. You take 10 women, same gestational age, you put them in a group, you have an OB there, a nurse practitioner, and they do a facilitated group discussion. And this is instead of regular obstetrical appointments for prenatal care. And they did a trial comparing this approach to standard prenatal care. The women check their own blood pressure, they weigh themselves, they fill out a questionnaire about what issues they're dealing with, and they talk to each other. And the physician and the nurse practitioner try not to answer their questions, they try to get the women to answer each other's questions. So they're really trying to empower the patients to see that they have agency over their own bodies and they know things that can help themselves. They're not completely dependent on the medical system to get through pregnancy. And the fascinating thing is that if you look at rates of prematurity and birth rates, breastfeeding, it's all better in the group than in the women who go in and have one-on-one care with the doctor. So for me, that was a very tangible example of let's stop being so condescending to patients and recognize the resources that they bring and empower them to take care of themselves. They'll have better outcomes. And there are other studies supporting the same thing, that if you get people actively involved in their own lives, their own care, give them responsibility, they do better. So giving the patient more control, letting them set the agenda. Why are they here? What do they want to talk about when we develop a plan? Do we check in with them to make sure the plan works for them, or do we just tell them what's medically best in our opinion? Both are important, but we often tend to focus on what we think they should do rather than what they're able to do or what they're willing to do. So those are the main points I wanted to make. We have a video on empathy that we developed at the Cleveland Clinic that I wanted to show because I think it makes some of these points in a more powerful way than me talking any longer would. And then I wanted to sort of get some discussion and questions and see what issues are alive for you and how I might talk to you about them. So I think at both sites we're able to do this.
Yes.
probably nothing to do with making that video, but I've always found it very powerful. I don't know, have people here seen it before?
Our volunteers are show it to every new volunteer coming to the hospital, just by coincidence.
Yeah, it's gotten a lot of play, even outside of the healthcare world. I'm curious what it means to people when you see it. Often it brings up a lot of emotion because it's dealing with serious stuff. But I'm curious if anyone has anything they want to share about it, what it means to you, or what it makes you think about.
Actually, it made me want to cry. I had to turn away because I don't want to start crying.
Yes, many of us cry when we see it. I've probably seen it like 60 times now, so I don't cry anymore. But
I think it really says that everybody's fighting a battle that we really know nothing about.
everyone's fighting a battle, right, that you don't know anything about. Everyone has a story. That's right.
I think when I look at it, I would like to think that I pay attention to people's social histories, and my patients I know very well, so that resonates with me. The interesting part is it's a long video, and so I'm listening to it and I'm thinking, oh gosh, there's one more. This is going to be the last one. Nope, it's not the last one. Then I thought, that's interesting actually, because it just never stops, right? Like, it doesn't matter how many people you walk past in the day and how long our days are, everybody has a story. Everybody does, like all of us in this room. So anyhow, it's a very moving video.
When I was a psychiatrist, I always felt very jealous of you guys, oncologists, because you exactly know what's going to happen to the patient. You can give statistically, and Snyder is listening to me, but I don't think I can walk on your shoes more than a day, because I'm a psychiatrist. I really enjoyed the way you presented it and the way you experienced it. The most interesting point you said that I want to highlight is that we are hardwired as human beings, even as a primate, you are compassionate. Right? And one of the areas that I like to, my colleagues to think is, when they have compassion fatigue, they should take a moment, look at what's happening in their lives. I think that's what Margaret was saying, Hindi.
Yeah.
And I think you guys see this every day, people dying, and I don't have to do that. But at the end of the day, you've been in this profession for enough years. It's like a routine. People dying looks like going to Tim Hortons.
Right.
But I think you need to watch that as physicians. When you reach that stage, you don't feel the same excitement. Look, when some places nurses do. You need to look at what's happening to you, what you need to do to get better. And I do have a lot of experience with clinicians, physicians in my work. And I think that's something that they should look and get better for themselves. Thank you.
Yeah, no, I appreciate it. So I think this issue of compassion fatigue and resiliency is hugely important. So in my field, actually in oncology, burnout is a huge issue, but it's not the only field of medicine where it's a huge issue. And what we do to recharge our batteries, and I think that's part of the power of the video, is that it's not just patients' stories, right? It's also the nurses and the doctors and the techs in the hospital, that everyone has something they're going through. And the other reminder is that if we don't ask and talk to them, then we don't get to hear their stories. And I'm not saying that we should know everybody's story, because that's impossible. We wouldn't get anything done. But what about the people who we work closely with? It's striking to me, for many of us in our daily work lives, we stick to very safe, trivial subjects. And we don't talk about stuff that actually really matters to us. So we talk about sports teams, the weather, the traffic, the parking, the economy, but how much
has been a big help.
And the iPhones have not been a big help, because then we don't talk at all and we just look at our email. But it's interesting to know these stories, and if you get to know the stories, that's how you form a connection and a relationship with the person. So that's another sort of underlying message.
Looks like it might be. I think that's Dr. Ken Schneider. I'm guessing.
Oh, good.
Has a question. He's
Do we have a way to communicate?
Hi everyone. Can you hear me on that side?
Yes, this is great.
Hi, Dr. Gilligan. I'm a radiation oncology, Ken Schneider from Windsor. Your talk is really, despite practicing for 23 years, the comments that you're making and some of the stories that you tell are absolutely real. I think we all know that when we practice in all areas of medicine, in all the other allied healthcare areas as well. It affects all of us. Just a bit of a comment first is the challenge that we have, not only in oncology, but all of medicine, where you have these challenging interactions with patients, and you do your best to understand the patient in addition to treating their condition. And then you've got that mindset and that kind of dilemma where you're booked in your clinic and you have to kind of change face within 5 minutes because you got another room to go into. And how, this is just a comment, how do you regroup when you really want to connect with the patient, manage their care, listen to them, and then you got 5 minutes to go in another room and do the same thing again, and you do that all day long? I don't know the answer to that question. Some of us are better than others at it, and it's definitely a learning curve as you practice medicine. The other thing that I sometimes realize is that when we see a patient in front of us, that's the tip of the iceberg. That little few minutes of time in front of us compared to what they take away into their world, it's just something that I think about a lot, and it gives you a whole different perspective on things in terms of how you care for your patient.
Well, thank you. Those were both really great points. Your second point reminds me of, it used to bother me when I was an oncology fellow that I would see a patient, they would have terrible things going on, they have a terminal cancer, we would meet for, like you say, however number of minutes we had together, and then I would leave the room and I'd close the door and I'd realize I get to go to the cafeteria now and decide whether I'm having tuna salad or turkey for lunch. And they have to go home and figure out how they're going to deal with having terminal cancer. And the fact that my exposure to them was so brief and what could I do in that limited amount of time, I agree with you, in oncology it's a very salient issue. The issue of, I have a more specific response to the first point. I think it's really important. And it doesn't have to be in oncology, but we go through stress during the day. Maybe we have a bad meeting with a colleague or our boss, or maybe we have a patient who's going through something really tough and we really connect with them about it and get drawn into it. And then we leave the room and we have to go into the next patient's room. And we don't want to bring all of that into the room with us. We want to be a fresh face, give them all of our attention, not have in the back of our head still thinking about what we were just doing. And there's a lot of work on mindfulness around this that I think can be very helpful. Now, people hear the word mindfulness and they often tune out and it's too touchy-feely or whatever, but it's really about trying to be in each moment and not, when I'm here right now, worrying about what just happened and trying to figure out how to prepare for what's about to happen, but instead just being present. And there are exercises people can do. So to give a very trivial example, but one that I have found helpful for exactly this scenario, someone suggested to me that I just take 15 seconds and stand outside the room and concentrate on feeling my feet against the floor as a way of just getting my head out of whatever space it was just in and just to sort of be in my body for a moment. And it's interesting, I was reading this week in the newspapers about a study that they did with athletes around mindfulness. And they didn't call it mindfulness because athletes don't like that word, it's too touchy-feely, so they called it tactical training. And they took these BMX bikers, so they're biking, doing these races, doing these crazy stunts, racing really fast with minimal body protection, and they're thinking, there's got to be a level of fear, and that fear probably interferes with optimal performance. So they put them through this test where they put a mask over their face that is difficult to breathe through, because if you can't breathe, anxiety generates. And they measured their physiology. And then they put them through these tactful, tactical training, the mindfulness exercises, and they actually were able to temper the physiological response to stress as sort of imposed by this not being able to breathe through the mask. So the point of the study was that mindfulness exercises actually can change how our bodies respond to stress. That it's not that you don't feel the stress, but how you react to it. You start to get a little bit more control over how you react to it. How do you stay in the moment even though you just went through something somewhat traumatic or you're having stress coming up in your life? And so I actually think that for people who are willing to do it, some work around mindfulness, around presence, can be hugely helpful to us and also can be helpful to our patients. Because if our patients feel that we're fully there and we have all of their attention, then they have a much better experience. If you talk to patients about doctors they'll often say, the doctor made me feel like I was the most important person, or the nurse made me feel like I was the most important person. And I think you have to be present to do that. And so mindfulness is one way of getting there. Because right now we live in a world that's very anti-mindfulness, you know, with our iPhones and our computers and our email and our pagers and our texts and we're always multitasking, and then are we ever really fully present in doing one thing? So I think it's a hugely important point, but I also think it requires us being willing to learn some skills for how to do this, whether it's meditation or other kinds of exercises.
In the patient advocate role, that's one of the biggest complaints that we get is the doctor came into the room, he or she stood the whole entire time and had their hand on the door. So there's that feeling that the physician group is pressed for time, so many people to see, but actually taking the time to even pull a chair up and sit and put away the charts and the phones and everything and actually engage somebody in a conversation would probably save a lot of time in the long run by answering those questions at the time,
Right.
and making sure they understand what's happening and, like you said, establish that relationship. Then dealing with the complaint after, where we're, we're going through the motions of, pulling somebody back into the room, trying to sort out the bad feelings. And
Well, and the sad thing is it doesn't actually save you time to stand and have your hand on the doorknob. It doesn't save you any time. If you spend the same amount of time and you sit down, it doesn't actually save you time. You're just sending a really negative message.
And Dr. Gilligan, Matt may not have heard what Robin said, but I think you captured it. But they would have just heard you, not Robin.
All right, sorry. So she was commenting on patients complaining that doctors stand and they have their hand on the doorknob and they look like they're in a big rush to get out. And I think that's one of our big pushes is to get people to sit down. They also, just the psychological impact of being at the same eye level is something I think we forget about. And I've learned this with my 7-year-old son, that if I crouch down and we're eye to eye, we have a very different conversation than if he's talking to dad like this. And it's funny because it makes me think of that when I was a boy and I like to watch wild animal TV shows or whatever. The big lion looking down at the little lions, or the big dog looking down. There's in mammalian, how we communicate with each other. If you're towering over someone, that's conveying power, and it's intimidating, and you feel threatened by it. If you're at eye level, that goes away. So I actually think there are many reasons to sit down. You honestly can have a better conversation with another person if you're eye to eye, usually. So but it's really hard to get people to do that. So our efforts to, it's been a big push to get people to sit in the room in the hospital and they go into it. When I shadow people around, we get at best 50% compliance. So it's a work in progress where I am.
Hey, if there are no other question, I'd like to take this opportunity to thank Dr. Gilligan. Tim, that was a very powerful presentation.
Thank you.
All of us are very touched. When we look at our hospital, we strive to provide outstanding care. But, medicine is not just knowledge-based, like you said. The art of medicine is how we communicate, how we go above and beyond caring for our patients. And that particular pause that we need to take and trying to appreciate the patient and the family, for that matter, is very vital. At the same time, I think as a healthcare team, we have to appreciate each other as well, because you really cannot, you like to treat the patient by yourself, but I think you need the whole team to provide the support and the compassion for the patient and their families. And I think that's something that we need to reflect on. I know that we have a lot of demands on our time in this hospital, internally, externally, but I think that's something that if you want to be in the healthcare system, you want to be a good healthcare provider, that particular, this little extra that we're going to carry around with us will help our life to be more enriched and more gratifying as a healthcare practitioner. To that, thank you very much, sir.
Thank you very much.
Experience Task Force, want to welcome you here today and over to the Met campus as well this morning. It is my pleasure and really my privilege to introduce Dr. Timothy Gilligan to you this morning. Dr. Gilligan is a medical oncologist specializing in testicular cancer from the Cleveland Clinic. He trains others and teaches communication skills and coaches physicians. He's already been here with us this morning, meeting with a number of our physicians. He's a faculty member of the American Academy on Communication in Healthcare and co-director of the Cleveland Clinic's Center for Excellence in Healthcare Communication. His interests include communication skills, facilitation, team building, feedback, and conflict resolution. I want to tell you that it was 2 members of our task force that heard Dr. Gilligan. Lisa Ruthven is one of them, Kelly Glaves is the other. They heard Dr. Ruthven in Toronto, and when they came back and reported to the task force, we asked them, what was the thing you learned at the conference? What was the best thing? And they said, it was Dr. Gilligan's talk. That's the thing we're going to remember. So that's why we invited him here today. So join me in welcoming Dr. Gilligan.
I'd be happy to take any questions that people have, or I'm curious how this has landed on you.
So, I'm a medical student, and part of our curriculum makes us write reflection about our experiences. And I wrote one to, it was an oncologist who responded, which is funny because you're also an oncologist. And I said that we need to find a way to introduce empathy in the curriculum. And she told me that you can't teach how to be empathetic, but you can teach them how to communicate. Do you agree or disagree with that? And how would you approach improving empathy in medical students and physicians?
And Dr. Gilligan, I just want to say that they wouldn't have heard the question.
All right, thank you.
Yes,
so the question was, can we teach empathy, or can we?
Oh, they heard it. Sorry.
Or can we only teach how to communicate? So I think the question is based on a false premise. Human beings have natural, hardwired empathic capacity. And if they don't, then they are sociopaths, and we will not have much success working with them. But the vast majority of people who you work with are hardwired to have an empathic response, and they have learned to blunt it. They have learned to protect themselves. It's hard in medicine. We see severe cases. We see terrible things happen to people. And if we're too exposed and too out there, we get beat up by it. And so we learn to put on our bulletproof vests and protect ourselves and our white coats and things like that. So I don't think it's a matter of teaching people something they don't know. I think it's a matter of helping people to access a capacity that they naturally have. And in some ways, it's about making it safe to do that. And there are very specific ways in which we discourage people from doing that. There's a beautiful piece in the New York Times a couple of years ago from a pediatrician. I'll probably get emotional again when I tell it, because I think it's very moving. But she was in the room as an intern with a parent who had lost a child, and she started to cry. And her chief yelled at her about it afterwards and said that was very unprofessional. And then several years later, she was the chief, and she told the family the same news, and the father started to cry. And he apologized to her, said, "I'm sorry, I'm upset, I'll get my act together." And for her, it kind of broke her heart, because how would she become a doctor who a father would apologize for crying over the death of a child? She asked herself, like, what have they done to me? And that's not the person she wanted to be. So I'm sorry to get emotional, but I feel like I've been there. We have that capacity to connect. I think we do tend to feel things. And we have to make it safe and acceptable to physicians to show that they care and that they feel and that they can appreciate what's going on. It's not a matter of suffering in the same way the patient does or going through the same experience as the patient, because we can't do that. But we can start to imagine what it's like to walk in their shoes, and what does the world look like from their perspective. And who knows that? The patient knows it. So if we just ask them, they can tell us. But then that gets us back to the listening and why listening is so important. And by listening and then hopefully expressing empathy. And in some ways, when I say expressing empathy, what I'm trying to do is I'm trying to let the patient see that I get it. That at some level I get what they're going through. Not that I can fix it, not that I can make it okay, but that I see that what they're going through is hard, and I honor that. I honor their struggle, I honor their journey, and I want to help. I want to support them. I can't magically make everything better, but I want to help. And so in a sense, it's getting students and doctors to stop protecting themselves from their vulnerability around that issue, and being willing to go there and being willing to feel and be willing to show other people that they feel. But in some ways in that question, though, there's the point of, well, if we script empathy, is it really empathy? And does it start to become artificial? And do you start to sound like a customer service representative? And I actually think that's a tough challenge, because if you take someone who's not used to doing it at all, they have to start somewhere. And starting with a script can help them begin. But you have to see that script as the first step of a longer journey, that ultimately the language starts to become natural. You use your own words, you choose your own phrases. But if you have no idea what to say, it's very helpful to have a few safe phrases you can fall back on. I mean, and it's not, it's not that hard. I mean, honestly, for many of my patients, I can say, how are you coping with having cancer? It must be really overwhelming. That's not a terribly profound or artful thing, but at least it gets the job done until I know them better and can say something more personal. So I think the authenticity piece is where, for me, that is the interesting question there, is how do you make it authentic and real? Because if the patient feels like you're just reading a script, then it sounds like you're the person on the phone in India, when you call AT&T or whatever, and they say, I'm sorry you are having trouble with your phone service. And, it must be very difficult for you. So that's making it authentic, making it real. So the other way we often put that is we're not trying to make clinicians sound as if they care. Because if you don't care, then you should not be in healthcare. What we are trying to do is to allow you to show how much you care to your patients, because your patients aren't seeing it. They aren't experiencing it. You're spending hours and hours studying, you're reading their records, you're calling colleagues to get advice, you're trying to make sure you're doing the right thing, and the patient doesn't know that. The patient only knows what happens when you're in the room with them. So if you're putting all this work into taking care of them and you care so much about what happens to them and they never see it, that's kind of sad. And so we're not trying to make people act as if they care. We're really trying to show them, if you care about someone, this is what you need to do, otherwise they don't know. And honestly, I think, I don't want to sound stereotypical, but I think a lot of marriages would benefit from similar advice.
Do you have any advice? Like, a lot of our patient population doesn't communicate very well because of dementia or stroke. Do you have any advice for those types of patients? Like, I actually have a patient on the 8th floor with you, and he has like no motivation right now. He's had a stroke. He's in his 50s, and it's just hard for him to communicate back, to explain why he doesn't want to eat, why he doesn't want to do physio. Do you have any advice in that type of situation?
Well, I think when you get into impaired capacity, everything is different. And if someone doesn't have the capacity to understand or doesn't have the capacity to communicate, then how much you can communicate with them is limited by their disease. And sometimes talking to the family becomes more important than spending a lot of time communicating with the patient. It depends on the individual situation. I think in someone with a stroke, I would talk to a neurologist to get a good sense of what we are going to be capable of accomplishing. But it's, I think, if I'm communicating, it's to connect. And if the patient is so sick they cannot connect with me, then spending a lot of time trying to connect with them is not time well spent. And it may be much better spent if I talk with their daughter or their son or their spouse and connect with them around this and figure out from them, what we need. And often they have valuable information about what the patient is capable of. So I think there are times that, for medical reasons, we can't really form a strong connection with the patient. And actually, it's one of the reasons I went into oncology. I thought I was going to be an intensivist, and I was as an intern in the ICU, and all my patients were intubated, and they had so many wires and lines, I couldn't even get close enough to them to put a stethoscope on them half the time. And I felt like, this doesn't feel like the kind of medicine I wanted to practice. I want to talk to my patients. So I went into a field where people were not intubated, and I could have a conversation with them. So I don't think there's an easy answer.
Yeah, thanks.
I have a question. I'm wondering, when you started this work at Cleveland Clinic, how did you get engagement and buy-in from your colleagues to work with you?
It's a great question. So we thought about this a lot. Tony Back at the University of Washington gave me a great piece of advice. I called him up. I said, we're rolling out this program. Give me one piece of advice. He said, you need to avoid failing in the first 6 months. He said, if you roll out a sucky program and the word gets out, they're going to pull the plug. He said, the way you avoid doing that, he said, get all your friends to come and take the class. So they'll go around and they'll say it's great, even if it's not. And they'll tell you what you need to do to make it better. So you can have your failures in front of a safe audience. And so we did that. We got other people who were really interested in communication to come and take our course. They told us what they liked. They told us what they didn't like. They allowed us just to get the kind of experience you need to do anything well, because we weren't very good at first. And then they went and said, that was a great experience. You should take it, you should take it, you should take it. And we got 1,000 people through on a voluntary basis. And then they said it was mandatory and the rest of everyone else had to take it. But by the time we made it mandatory, we had a smooth running machine, good product, and we had figured out what to do when you have a difficult group or things like that. So I think trying to stay invisible for a little while so you can work out the kinks in a safe environment. And only, it's sort of like Broadway shows, like they come to Cleveland before they go to Broadway. So that by the time you're in Times Square, they've worked out all the mistakes. So that was very helpful. And then the second thing is it was very much homegrown. So first of all, we only had busy clinicians teach it.
Yeah.
So when I go and I teach this class, I spend half my time in clinic with cancer patients. So I know what's hard about seeing patients. I have time constraints, I have charting restraints, so it's not like I'm some expert from the Ivy League who's come in to tell them how to do their job. I'm one of their colleagues. And we tried to think of how to build the program in a way that was very respectful of their own experience and their own culture and what was going to resonate with them. And so that they saw us as colleagues coming in to have a shared conversation about a shared challenge rather than experts telling them how to do their job better. Because these are doctors who've been in practice for 10, 15, 20 years, and you can't go in and say, I know how to do your job better than you do, right? So those are the two main things. Sensitivity to what's going to work in our culture and going off Broadway before going live.
And I just want to give Met an opportunity, if there's someone at Met with a question. Kathy? Any questions over at Met?
We're good, thank you.
Okay.
So first of all, I want to thank you for the talk, because I thoroughly enjoyed it. Now, I know in our nursing education, we actually do classes on therapeutic communication and role playing, and so intervening early on in education is important. Are they changing curriculum in medical school to incorporate this type of education?
So it's a good question. What's going on in medical school with including this? I actually think medical schools, at least in the US, have been leaders in this area. What makes me most optimistic is that the people coming out of training now have gotten much more attention to this. They actually, part of their board exams now is a clinical encounter with a patient, so they have to demonstrate their interviewing skills. And in our medical school, we have regular role play sessions as part of their, we don't really have grades per se, but as part of their curriculum they have to pass of how they communicate, and they get very structured feedback around communication skills. So I think medical schools are really starting to take this much more seriously. It's a relatively new development, and so physicians currently in practice, for the most part, haven't had that, or the ones who are coming out of medical school. And I think it really makes a difference. One of the medical students I supervised, when he came out of school, he did his residency at our hospital, and his first month he was on oncology, and a patient died that month who he was taking care of, and we got a note from the family about how wonderful a communicator was and how caring he was. And I think it wasn't an accident that he had as part of his training very structured, very supervised communication skills, so he was not intimidated by going into the room by someone who was so seriously ill. So I'm very hopeful about the future, I really am. And I think medical schools are taking that seriously. In fact, when we built our program, we stole the person in the medical school who was doing it because we felt like she was doing such a good job. I mean, she didn't stop doing stuff at the medical school, but I don't mean to say we sabotaged them. but we took her because we were like, whatever you're doing is great, so we need some of that for our doctors. So. Are we out of time? I think I have to let you go. Thank you for coming.
Thank you.
Those of you who don't know me, I'm Lisa. I'm from the pharmacy here at the OLET campus. I'm also a member of the Patient Experience Task Force, and we heard him last year in Toronto, and that's why he's here today. So I just wanted to say thank you very much, and I know I've taken a lot from it, and I hope other people have taken at least one piece of the puzzle back with them.
Excellent.